My name is Mark Van Cura. I'm going to give you a lecture on acid-base balance and the imbalances that we go through in basically the human body. And this is Marco Urabazo, who's our videographer and editor, and he may be asking a few questions that are pertinent or things that a student would typically want to know as we go through this. Acid-base balance is probably one of the most important topics to understand, because I always say, that either you're going to get struck by lightning or hit by a bus, massive heart attack or stroke, or you're going to end up in an intensive care unit in acid-base imbalance. And so whether I went to a NICU, a neonate intensive care unit, or an intensive care unit, and in a hospital, I would see people on ventilators and monitors. So we're going to try and go through that and understand the concept of acid-base balance, and then a term called ABI. So the first thing we're going to do is we're going to memorize a formula called the acid-base formula. And that's going to be CO2 plus H2O in a reversible reaction, that's the two-sided arrows, are going to yield H plus HCO3 minus. And so CO2, as you all know, is carbon dioxide. Remember, carbon dioxide, if you think of the respiratory system, that's really the main trigger for respiration in a person that's normal or doesn't have a pathology such as COPD. Whereas if a person had COPD, their trigger for respiration would be too little oxygen. So it would be versus a hypercapnic drive in a normal person, or a hypoxic drive in a person that was with COPD. The next part of the thing, remember, carbon dioxide is going to be considered to be acid forming. Then we've got H2O, which hopefully we all know is water. But always think of water as being a neutral solvent. And you have water and you put salt or put anything in it, those are dissolved into and make a solution. So think of water as the neutral solvent. And of course, the body is mainly made up of water, and it's never really an issue until we hemodilute or hemoconcentrate, since like I overdrank too much water, or I was out on a hot day and my electrolyte loss caused me to hemoconcentrate. And then you've got this reversible reaction here, and therefore I've got to put in here now, so CO2 plus H2O, and that's going to have this reversible reaction. And let me just stick it in here so you can understand this. So remember, that's going to form something called H2CO3. So carbon dioxide plus water are going to yield H2CO3, which is carbonic acid. So just by its name, it's an acid. And then that carbonic acid is going to be a reversible reaction. And that's going to have my dissociation into hydrogen ion plus bicarbonate. So the H plus is hydrogen ion. And that's going to be an acid. And HCO3, which is bicarbonate, which is a base. Okay, so that's your acid-base formula. So we're going to try and get rid of some of all this writing in here and just rewrite the formula now that you understand what those are. CO2 plus H2O in a reversible reaction is going to yield H2CO3 plus H plus yields H plus HCO3 minus. So that's my acid-base reaction. And we know that the left side of the equation is going to be called the respiratory component. The right side of the equation is going to be called the metabolic component. And the HCO3, of course, is going to be the product, or considered to be a buffer. So think of CO2 and H2O being reactants. And when those two reactants come together, they form a product. And then when that product dissociates, it forms reactants again. So just to make it simple, just think that if you were to increase your carbon dioxide, which we've already said is acid forming, and you added it to water, you'd end up with more product. So it's a direct relationship. If I were to increase my CO2 acid, I would end up making more H2CO3, which is acid, and therefore that would change my pH. So the same thing on the other side. When I increase my H plus or HCO3, that's going to change my product. So just remember, you've got a metabolic side and a respiratory side. And those two you have to keep in order.
So I got a question for you. So what systems of the body are involved in acid-base balance?
Okay, well, when you think of acid-base balance, just remember that first word we said was respiratory. So that's going to be the lungs. So it's the respiratory system. And of course, that's going to be my lungs. And then it's going to be, the other side is the metabolic. And of course, the metabolic is going to use the renal system. And of course, remember, renal system is your kidneys. And at the same time, it's going to use my digestive system. And therefore, the digestive system is going to be, for example, like my stomach. Or a significant organ is going to be the pancreas. So those are the systems that are going to be involved with maintaining my acid-base balance. Now the next thing we have to do is memorize what are called some values. So therefore, there's what are called normal values to memorize. And so the first thing you want to memorize is your pH. And your pH N for normal is going to be 7.35 to 7.45. Now some of you maybe are familiar with the pH scale. And I always tell students, first thing you want to do is remember there's really two pH scales. You've got a pH scale that you learned in chemistry, and you have the pH scale for anatomy and physiology, especially the human body. In chemistry, you're always going to say, well, there's a 7 here, and 7 is going to be neutral. You could theoretically go up to 14, and it could go down to 1. As I go up from 7, if that's neutral, as I go above 7, it becomes alkaline. As I go below 7, it becomes acid. In A&P of the human body, I still can put down this 7 here. I still can bring it up to 14, which would be an impossibility because we'd be dead long before then. And I could still bring this down to 1, which again is an impossibility. But in the human body, that neutral number is going to be 7.35 to 7.45. So therefore, anytime I'm above 7.45, I become alkaline. And anytime I'm below 7.35, I'm acid. And the best example I can give you is that if you were working as an intensivist or working as a nurse in an intensive care unit, and you saw a patient on a ventilator and looked at his ABGs, arterial blood gases, and you also looked at the monitor for the settings, and someone said to you someone had a pH of 7.2. So if someone came to you with a patient with 7.2, you'd have to put your thinking cap on and say, well, you know, in chemistry, a 7.2 in chemistry, well, I'm looking up here, a 7.2 in chemistry is alkalosis. Except your patient we're dealing with is under anatomy and physiology scale. So therefore the pH of 7.2 in the human body, or I call that A&P, well, if I look over here, 7.2 is going to be acidosis. It's very common for someone on a ventilator to have someone not think quickly enough or think enough critical thinking and use the wrong scale, and it's just a ventilator setting, and now you've got a patient that's critical or near death. So that leads us to what are called the acid-base imbalances, and to understand those we just have to write a couple more values down here. I know that there's an N for the what's called the partial pressure of CO2, and that's going to be 35 to 45 millimeters of Hg, which is mercury. And then the N normal for HCO3, remember that's bicarbonate, and that's going to be 22 to 26 milliequivalents per liter. Okay? Normal values, memorize. Formula, memorize. Understand what systems are involved. And now we can go on to what are called the ABIs, or acid-base imbalances. In effect, there's 4 acid-base imbalances. And classically, those are called an ABI. All of you probably have had blood drawn, and when you went in, when they drew blood from you, they did a venipuncture. Remember, a venipuncture is going to be taking venous blood. But if I needed to do our blood gases, I'm going to need arterial blood, and I'm going to do an arterial stick. So it's not venous blood, it's going to be arterial blood. And these are based upon that arterial blood draw. So now if we think about the 4 ABIs, let's start out with one, and let's call it respiratory acidosis. Well, respiratory tells me that the cause of the problem is the respiratory system, so that's the cause of that person's problem. Acidosis, because we're using the pH scale in the human body, means it's going to be less than 7.35. Now we have to just write down those values. Remember I said the values to memorize are going to be my pH, my PCO2, partial carbon dioxide partial pressure carbon dioxide, and my HCO3, which is my bicarbonate. And then the body's very unique because, we're such a homeostatic body and mechanism that we have 3 levels of compensation. We have a UC, which stands for uncompensated. We've got a PC, which is a partial compensation. And we've got an FC, which is going to be full compensation. Just think of full compensation as the best my body can become unless there's intervention. So now we want to fill in this chart. Well, let's see. If we go back to that equation, and I don't want to keep going and repeating it over and over, but if I just remember going back to the equation I just wrote for you, remember that in that equation, the left side of the equation was the respiratory component, and the right side of the equation was the metabolic component. And sure enough, there's your CO2, and that's on the respiratory side. So therefore, when I'm looking at this, I'd say, well, I know that my pH scale, if it's acidosis, tells me it's going to be less than 7.35 or down. I know that my PCO2, since it's a respiratory cause, that's the cause of the problem. And that's, again, going to be looking at the respiratory side. And if I already said that the values, remember the values are 35 to 45 millimeters of mercury, and then my HCO3, that's going to be the compensator. So I've got a cause, I've got a compensator, and I've got a pH. So let's fill in this chart. Well, when I'm uncompensated, my pH is going to be down because that means I'm less than 7.35. The cause of my problem means my PCO2 is off. I'm in an acidosis state. Do you remember I said that acidosis values, acid is and CO2 has a normal value of 35 to 45 millimeters of mercury. If I'm in acidosis, I've got too much CO2 because the formula told me it's acid forming. So my PCO2 levels are up. And because I'm uncompensated, therefore my HCO3 is the compensator, and I'm uncompensated, so that's totally normal. When I partially compensate, my pH is still going to be down. It's still less than 7.35. I still got the problem. My PCO2 is up. And now I've got to compensate. Remember on that formula, HCO3 is on the right side. If my body is in an acid state caused by my lungs, I've got to go to the metabolic GI renal system and say, please help me out. My body is then going to take HCO3, which is a base, and it's going to increase the HCO3 levels. So my HCO3 will increase. Now I'm going to fully compensate the best I can become. My pH is now going to be what's called a LN, or a low normal, and I'm going to use the number of 7.35. I still have the problem. My PCO2 is still up, and I'm still compensating by retaining bicarbonate, and that's still up. So that's my first acid-base imbalance.
How about another one? I guess respiratory alkalosis.
Okay, so again, if we look at respiratory acidosis, I guess the next thing we maybe should think about before we go to your alkalosis is
metabolic acidosis.
No, but let's just think for a second. If we've got someone in respiratory acidosis, I want to think about the patient.
Oh, that's
true. I want
to
think, what's an example of one of these patients? Because we're all going to be, or hopefully, practicing in some type of allied health field. And so therefore, when I think of respiratory acidosis, I know it's a person that has a lung problem that's pH is down. And so you're going to start thinking of a couple patients. The first patient of respiratory acidosis is so I'm going to write these different examples of patients. Well, let's see. If I've got too much CO2, am I breathing too fast or too slow? Well, the answer is I'm retaining CO2. So memorize the thing that hypoventilation always causes respiratory acidosis. So let's think of why someone would breathe slow. Well, number one is someone that's got a drug overdose. You know, if someone takes opioids and benzodiazepines, they're respiratory suppressants or depressants. And as a result of that, when I stop my breathing rate, which is normally like 16 to 20, or some people may say it's like 14 to 18, there's no definitive answer to that, I'm going to retain CO2. And if I stop breathing completely naturally, my CO2 levels are going to go drastically high. What's another great example of it? Someone that just had surgery. You know, if I had abdominal surgery, so I'm in what's used to be called the recovery room, and of course now we call it the PACU, or the post-anesthesia care unit, and I had abdominal surgery, I don't want to breathe. Well, when I don't want to breathe, it hurts to breathe, so I'm going to hold my breath as much as possible, not do deep breathing, and that's going to cause me to go into a respiratory acidosis. Finally, another great example is COPD, chronic obstructive pulmonary disease or disorder. Used to be called emphysema. And just think of COPD equals a fully compensated respiratory acidosis. So that's my first ABI, and those are my patients to remember for that. And remember, the cause of this person's problem was they were hypoventilating, and they were compensating by using their metabolic side. Remember, it's going to be very slow to compensate, because if I cannot tell my kidneys to do anything, so it's got to take time. I can't tell my GI tract to do anything. It takes time. So when I have a respiratory problem, I've got to call on my metabolic side, but that's going to take time. Time is sometimes not your friend. Well, let's see, if that's respiratory acidosis, I think you asked me a question, what about metabolic acidosis?
Yeah.
Well, let's see, metabolic acidosis. And all we do is go through the same exact thing. We know metabolic's the cause. We know acidosis means the pH is down, decreased pH. We put our same acronyms up there. PC, we're going to put PCO2, pH, and HCO3. Those are my three values. I know I'm going to have a UC, uncompensated, a PC, partially compensated, and an FC, fully compensated. I know that pH, if it's acid, is going to be down. I know if it's metabolic, remember I'm going now to the right side of the equation. So if you looked at the right side of the equation, remember the right side of the equation had H and HCO3. So now I'm on the metabolic. So I'm looking over here now and saying that instead of CO2 being the cause, HCO3 is the cause, and PCO2 is the compensator. Let's look at the values. When I'm uncompensated, my pH is going to be down. My cause of the problem means if I'm in an acid state and my cause is bicarbonate, which is a base, I have what's considered to be a base deficit. And therefore the base deficit is causing the metabolic problem. So my HCO3 is going to be down. And since I'm uncompensated, my PCO2 is going to be normal. Now I'm going to compensate. Except now it's easy to compensate. I can sit here and hold my breath. I can change my respiratory rate. I can hyperventilate, or I can breathe very slow and hypoventilate. So therefore, it's quick to respond to a metabolic acidosis, except how long can you hold your breath, or how long can you breathe very quickly? So now when I partially compensate, my pH is still going to be down. My cause of the problem is still there, my bicarbonate's down, and now I'm going to compensate for that. Well, the only way to compensate is if CO2 is acid forming and I'm already in acid state, I have to get rid of acid. So therefore my PCO2 levels are going to start going down. Now I'm going to fully compensate. I'm going to end up in what's called a low normal. Remember, low normal is 7.35. I still have the cause of the problem. HCO3 is down, and I'm still compensating with PCO2 is down. But now what we're learning is, how in the world am I going to get my PCO2 down? Remember I said in respiratory acidosis, hypoventilation always causes respiratory acidosis. But now we're going to say that hyperventilation, or breathing fast, always compensates for metabolic acidosis. So therefore, when I breathe quickly, I'm going to get rid of CO2, and therefore it's going to balance me out. And again, the same thing you say to yourself. What would be an example of someone in metabolic acidosis? Well, a good example of metabolic acidosis is something called DKA, which is another name for diabetic ketoacidosis. A lot of you are very familiar with the Atkins diet, or the ketone diet. And therefore, that's an artificially started way of getting your body to, instead of taking in sugars, it's going to break down my fats, and it's going to break down my protein sources in order to control my blood sugar. So therefore, kind of think that in a normal person, you're going to undergo glycogenolysis, but in the ketoacidosis or the ketone diet, you're going to undergo gluconeogenesis, the production of glucose from a non-sugar source. Okay, so that's a really good way to think of a metabolic acidosis. And again, there's several different ways you could find yourself in that situation, but DKA is your classic one, especially in the medical field. The next one we want to talk about is, naturally, there's the other side of the coin. So we talked about the acidosis states, and now we want to think of the alkalosis states. So let's now talk about respiratory alkalosis. Well, let's see, respiratory alkalosis. Respiratory is the cause of the problem. Alkalosis means that my pH is up, so increased pH. Remember, I'm looking now at the left side of the equation. Cause of the problem, pH is up. Same things I put down. pH, PCO2, HCO3. Of course, then I'm going to have my levels of compensation. UC uncompensated, PC partial compensated, FC fully compensated. Uncompensated, well, remember the pH, PCO2, HCO3, it's a respiratory problem, so this is the cause of the problem. This is the compensator of the problem, and this is the pH level, which we know is going to be up. So I know in uncompensated respiratory alkalosis, the pH is up, greater than 7.45. The cause of the problem means that my PCO2 levels are what? Well, they're down. So therefore, just remember before we put this down that when I've got respiratory, it's going to be hyperventilation. Hyperventilation, or breathing fast, always causes respiratory alkalosis. So if I look at this now, I'm uncompensated, my pH is up. The cause of the problem means that I'm losing CO2 by breathing fast, so this is down. And because it's uncompensated, this is normal. When I start to compensate, now I'm going to call on my metabolic side and say, I need some help here. Remember, that's going to take time because it's difficult to compensate for a respiratory problem. So when I partially compensate, my pH is still going to be up. My cause of the problem is still there because I haven't intervened. And now my HCO3, remember HCO3 is a base. I'm not going to tell my GI tract and my kidneys to retain base. I want to lose base. And therefore my HCO3 levels are going to now start going down. So remember in these values, if this was 7.35 to 7.45 was normal, and the normal for PCO2 is 35 to 45, and the normal for HCO3 was 22 to 26, my values here are going to start going down. I'm going to be less than 22. My PCO2s, because I'm hyperventilating, be less than 35. When I fully compensate, I'm going to end up in a high normal state, which is going to be 7.45. I know that my cause of the problem is still there, so that's still going to be down, and I'm still compensating, and this is down. And now I just have to think of a couple of patients. Who tends to breathe fast? Well, here's your patients to just remember. Number one is a woman in labor. She didn't memorize or follow her Lamaze classes. She hyperventilates. She goes into a respiratory alkalosis. What's another one? A child with a fever. A child with a fever tends to hyperventilate to try and cool down his body. What's your third one? Panic attack, test anxiety. That's why when people get anxious about a test, they breathe fast. When they breathe fast, they get tingling in their hands. They feel kind of upset to their stomach, and they actually don't feel well at all. And the reason being is they're hyperventilating. So that's my respiratory alkalosis, and that only leaves us a last one to look at, and that's going to be the metabolic side. So the last one now is metabolic alkalosis. Remember, metabolic alkalosis says metabolic's the cause. So I'm looking to my GI tract, I'm looking to my kidneys. Alkalosis, I'm going to think about what? Well, I'm going to think about alkalosis is going to be the pH is going to be up, increased pH. If metabolic alkalosis, like the other one, is going to have a pH, PCO2, and an HCO3, and I'll go back right now when I finish this one and show you how these two, that's why I always hold off before I do the second great example, is in metabolic alkalosis, we've got, again, UC, PC, FC. Let's see. pH and alkalosis, well, let's see. That's going to be down. That's going to be up, right? Alkalosis greater than 7.45. If it's metabolic, cause is over here. Compensators over here. pH is up. Metabolic alkalosis, the cause. I've got too much base. HCO3 is up. This is the compensator. I'm uncompensated. It's going to be normal. When I partially compensate, my pH is going to still be up. I still have the cause of the problem. HCO3 is up. But now I'm going to say, how do I compensate? Well, just think that in order to compensate for a metabolic problem, I've got to retain carbon dioxide. So now, hypoventilation always compensates for metabolic alkalosis. When I get my breathing rate down, I'm going to retain CO2. So therefore my PCO2s, when I compensate, are what they're going to do. Well, I'm going to retain, they're going to start going up. And then I'm going to fully compensate. When I fully compensate, I'm going to find out I'm in what's called a high normal state, or a 7.45. I know that my cause of the problem is still there, so the HCO3 is up, and I'm still compensating by hypoventilating. Now we can see these two different patients, and we're going to understand something. And of course, when I think of metabolic alkalosis, one example you would say is an over ingestion of antacids. That's one way. But the other way is if I think about my GI tract, and that's where I tie the two together, the metabolic alkalosis and the acidosis. Remember your stomach. So here's your esophagus. If you think of anatomy, here's my esophagus. Remember, my esophagus is going to pass into the stomach. So there's my stomach. And remember, the stomach has got parietal cells. They're going to produce HCl, or hydrochloric acid. And remember, my esophagus and my stomach, are they going to pass into the small intestine? I'll make this very simple. So there's my SI, or small intestine, my duodenum, jejunum, ileum. The small intestine is going to pass through that cecum until I get into the large intestine, the LI for large intestine, and then finally ending up in the rectum. So therefore, the question you ask yourself is, what would be an example of a patient that's in metabolic alkalosis? Well, let's see. If my stomach produces hydrochloric acid and I was to vomit, when I vomit, I'm losing hydrochloric acid. The hydrochloric acid is coming up when I vomit. When I lose hydrochloric acid, it's an acid deficit. When I have an acid deficit, it causes me to go into a metabolic alkalosis, and therefore the answer is vomiting is a great example of having metabolic alkalosis. And now that we know something about the anatomy of the body, we're just going to go back to the metabolic acidosis, and rather than redraw the entire thing, remember, here's my esophagus, here's my stomach, here's my small intestine, here's my large intestine. So this is my SI, this is going to be my cecum, and this is my large intestine. And this is my rectum again. Well, let's see. I know that the small intestine has three portions. Remember, there's the duodenum, there's the jejunum, and there's the ileum. Those are the three portions of my small intestine. Okay? Well, if I've got a patient that's in metabolic acidosis, the pancreas, which kind of fits its way in here, I'm just going to draw it kind of like this and show, here's my pancreas. And if you study the endocrine system, I know the pancreas has got the endocrine and the exocrine. Remember, the exocrine pancreas is going to produce HCO3 or bicarbonate. And therefore, HCO3 or bicarbonate is going to be released into the small intestine, then into the large intestine, therefore causes diarrhea. So therefore, if you were to go up here and say, what would be another great patient example of a patient with metabolic acidosis, that's going to be a patient with diarrhea. So therefore, just thinking the big picture here, if I've got diarrhea, what am I going to be doing? Well, if I got diarrhea, I'm going to be compensating by what? Hyperventilating. I'm going to breathe quickly to get rid of the acid because I've lost so much bicarbonate with the diarrhea. If I've got the patient with metabolic alkalosis, remember I said I'm going to compensate by hypoventilating. So when you've got the patient that's vomiting, when they vomit they lose acid, they go into a base situation or a base deficit, and therefore if you have a base deficit, what's going to happen? Well, you've lost acid, now you've got this, so to compensate for the metabolic alkalosis, hypoventilation is going to compensate for it. When I lose, so just to, again, I'll make this really clear to you. So remember, when I vomit, what am I doing? When I vomit, I'm losing acid. When I lose acid, I become alkaline. When I have diarrhea, I'm losing the alkalinity and I become acid. Okay? So that's something I'm going to make really, really clear to you, because that's where students get really confused. So I'm going to finally finish up by repeating a couple of things to you. One, you want to memorize that formula. CO2 plus H2O, reversible reaction, yields H2CO3, carbonic acid, which dissociates into H plus hydrogen ion plus HCO3, which is bicarbonate. Remember, this is respiratory. Remember, this is metabolic. The other thing you want to memorize is that hypoventilation always compensates for, well, remember, when you hypoventilate, you're going to compensate for a metabolic alkalosis. But remember, hypoventilation is going to cause respiratory acidosis. You're retaining CO2. What's the flip side of the coin? Hyperventilation. Remember, hyperventilation is going to compensate. Remember, when you hyperventilate, you breathe fast, and you breathe fast, so it's going to compensate for a metabolic acidosis. And then hyperventilation is going to cause a respiratory alkalosis. Okay? So again, big picture, when I vomit, I lose hydrochloric acid and I become alkaline. When I have diarrhea, I'm going to lose HCO3 and I'm going to become acid. And that explains how compensation works. So that kind of summarizes acid-base imbalance. Remember, when you're talking about acid-base imbalance, you want to understand the respiratory tract, you want to understand the renal tract, how the kidneys, how the way they're able to hold on to hydrogen ion or lose hydrogen ion, hold on to bicarbonate or lose bicarbonate. Same with the GI tract, specifically looking at the pancreas, because that is a unique organ that is an exocrine and an endocrine organ that produces bicarbonate and releases it into the duodenum. And then, of course, always remember that never memorize, but analyze. And when you ever look at any of these questions, always say to yourself, what are the normal values? What does the patient look like? And always think of that if you plug those numbers into those formulas and plug those into those charts, you could really never ever get the question answered incorrectly. Well, thank you, and have a great day.